What is going on, everybody? It is Mark, the lead faculty and CEO here at Modern Pain Care, where we make you the complete clinician. Coming at you this week with an episode related to some of the discussions we've been having again in our coaching group, and one that Jarod and I hold near and dear to our heart, as far as one that I've been fortunate enough to speak at CSM, or maybe it was APTA. I don't even remember what their other yearly meeting that no longer exists is called, but been able to discuss the osteoarthritis topic in the past, and it's one that I think, as a whole in a healthcare system, man, we still don't do well and do our patients justice by how we pathologize folks and limit folks a lot of times by labeling and nocivic communications around osteoarthritis. But today's episode, we're going to talk about dosing exercise around osteoarthritis, because it's a common question we get. There's a big movement in our profession that really incorporates strength and conditioning principles, which I think is a great movement. But there's a nuanced discussion I think needs to be had about when and how and with who that we're going to have today. But before we have that discussion, let's hear how Jarod's doing. How you doing, Jarod?
Doing good today, man. This is this is a topic I'm pretty excited about, and I think as you and I talked about beforehand, before we came on live, we can probably make 4, 5, 6, 7, 8, 10 episodes off of. We could talk for a long time on this, because exercise is one of the primary things that we do, and dosing exercise is one of the primary avenues of critical thinking and clinical reasoning that we use. And this is something that has come up literally almost every coaching call that I've been on with our groups. We're talking about dosing for different exercises and nuances of dosing, and dosing for different outcomes and different painful conditions and that sort of stuff. So it comes up a lot.
Yeah, definitely. And it's one that I definitely struggle with myself in my journey as a clinician, as far as who, how much, when, how do you know if you're going too much or too little? God, there's crepitus in this joint. Are you sure? I should be monkeying with that. I think we get freaked out about that as clinicians. But one of, I think, the common threads that we hear with it is just, in this thought of, like, again, strength and conditioning. I love it. The fact that we're getting into it, and, depending on your setting, that might be something that you're really incorporating more early on and right off the bat, if you're working in more of a performance setting. But a lot of us who are listening, work with more of a rehab setting, more, dealing with folks who are actively in pain, who are struggling. So there's probably a difference, there is a difference in my practice for sure. And I know in yours, when it comes to, hey, am I dosing for rehab or am I dosing for performance? So can you speak to a little bit of that those continuums, I guess, that exist in the clinic? Because there's just sometimes I think clinicians, we jump into, like strength and conditioning, let's go hypertrophy, strength, power, let's get after it. Which again, in the right client, for the right scenario at the right time, that's beautiful. Let's go. For some people, maybe not. So how do you navigate that in your practice, Jarod?
I mean, I think the first thing we need to do is actually talk about the swinging pendulum, right? I would say maybe 15, 20 years ago, based on my understanding and, when I was in PT school and all that sort of stuff, dosing exercise primarily seemed to kind of fall along this is rehab exercise. This isn't any other type of exercise. It's different. So we do things different because it's about motor control, and it's about endurance and these type of muscles, and it's about stabilizers, and it's about correcting posture and stuff, right? So you had this like whole rehab exercise mindset. And now I feel like, at least in a lot of people, there's like the whole pendulum thing where it's swinging so far over to say, well, all of your exercise, it has to be specifically programmed for power, or you need to be working on, specific muscle hypertrophy. You need to be working on developing this rate of force production. You need to be working on, creating X amount of strength in this particular muscle or this particular movement. And maybe some of the nuance of looking at patient specific factors and dose response when it comes to pain, has really gotten lost in the mix. There's not necessarily a lot of nuance there, because it's like the two ends of the spectrum of, well, it's rehab exercise and it's totally different, or no, exercise is exercise, and you just need to dose based on these parameters, which is falsely predicated upon the idea that pain is a result of muscle weakness, or pain is a result of decreased endurance, or pain is a result of the inability to produce a sufficient amount of power, or whatever it is. And we just really don't have any evidence at all that pain is caused by weakness, or pain is caused by, not having some arbitrary sufficient amount of endurance or power or whatever it is. So I think that those two ends of the spectrum have been going on over the last couple of decades. And as usual, the better and more reasonable approach is probably somewhere in the middle, and that probably shifts a little bit, back and forth with different patients at different time with different, presentations. What do you think about that, Mark?
No, I think it's probably what spurred this episode is just the pendulum. And we see, like, we've had some of our, like I said, coaching folks who are just load it, just load it. I just need to load. And I think, it comes to this, like, almost to where we're just like default to it versus a reasoned approach to when that patient fits towards the more strength and conditioning. And we're going to go after that versus just assuming that having a clinical process where you're going to let the case in front of you decide that, and not just impose our want to get folks chucking trap bars and barbells around, which I love the fact that we're doing more of it. It's just, again, I think we need to be more nuanced and not get to where we're swinging pendulums. And I think it's just human to learn something new and want to just like jump on the wagon and like get excited about it. And there's nothing wrong with that, but just, again, own the bias you bring into that context and don't try to impose it on your patient. Especially, how do you know if that patient's responding well to this kind of more strength and conditioning type, method of applying load versus maybe more nuanced, understanding that specific human's background with load, instead of just, again, going that. But I would agree. I think this we got to find the middle for most of our patients, and maybe we drift more towards performance, drift more towards rehab. But to dichotomize it, it's either this or that. I think you're going to set yourself up for struggles, because I think some of it can coexist. Both those sides of things can coexist within an equation. You might be able to do some endurance work on a patient who also is rehabbing. I've had folks where they're rehabbing a shoulder, yet they want to keep their cardio up. Let's go kill it on the air bike, the Airdyne, for a little bit and get you sweating, get you moving. And lo and behold, their retest on their shoulder starts feeling better because they're, pumping in a bunch of endogenous stuff into the system. So I think, again, the more, nuanced approach is definitely one, as always, that usually is probably a better thought process with it. Yeah, again, like I said, I'm happy that we're bringing in some of these principles. I've felt grossly underprepared for strength and conditioning principles in my practice. I think we had like a lecture or two on therapeutic exercise as far as when it comes to like the dosing type parameters. And then it was just like, felt like I entered the clinic like, oh, good luck, see what works. I don't know. We don't really have a lot to help you with. And then, we're lucky we got Joe Camerato and CJ De Palma who are going to come on and partner with us at Modern Pain Care for their Across the Continuum program, which is going to start tackling these loading issues with patients and starting to understand some of the specifics of this. But where do you think we could do better as far as choosing load for our patient and understanding maybe where we start with patients on loading? Especially, we're talking about osteoarthritis today, so I almost forgot that we're kind of more of a focused episode today. But where do you think we could better, tailor that load to maybe that rehab versus performance for the unique individual in front of us, Jarod?
Well, when we're talking about osteoarthritis specifically, I think that maybe some of the loading concepts that come about, or people's approaches are probably founded in a maybe a less than up to date concept of osteoarthritis, right? Because traditionally we've said osteoarthritis is this, wear and tear type of condition that, your knee only has, a million bends in it. And once you get to a million bends or a million squats, then it just starts to wear out and it starts to fall apart. So I think that has led us to maybe underloading people to some degree. But then conversely, we have a lot of maybe new age people saying, well, you have this osteoarthritis of the knee because your quad is weak, because we have data that shows that people with knee OA tend to have weakness in their knee, and in particular their knee extensors. So those people are saying, well, it's a kind of a post hoc reasoning to say, well, your knee must hurt because your quad is weak, instead of saying, well, maybe their quad is weak because their knee feels like shit and they're offloading it, and they have, protective, mechanisms at play that are reducing force output, or maybe they've been, disuse atrophy because it has hurt and they haven't bent their knee for years under load. So again, the kind of the two ends of the spectrum there. Um, but if we recognize that osteoarthritis is maybe this, metabolic process and sensitivity process where it's not necessarily about weakness and it's not necessarily about your joint being worn out or whatever, and we understand that your nervous system has two main things that it can do. It can either sensitize or it can habituate, right? And if somebody's knee really, really hurts and it's flared up and it's painful, well then maybe it's sensitive right now. And what we need to do is try to habituate that. So we need to find a dose of exercise that can, or a dose of load that can start to stimulate that area, start to exercise, start to add any sort of load to that area. And then we assess the response to that load, right? We see if there's a dramatic flare up. We see if there's a little bit of pain during. We see if there's a mild flare up that's gone within a few hours or gone within a day. They recover really quickly. So then we need to start thinking about, in this way, we need to start thinking about volume, intensity, and frequency. Right? These are the three things we probably really, really need to think about when we're looking at dosing up somebody with knee osteoarthritis due to sensitive pathways in their knee and sensitive tissues in their knee as a result of this metabolic process and gradual, peripheral sensitization, neuroplastic changes. And we need to maybe not think about how much weight is this and does the rep range fall into strengthening or hypertrophy or power or whatever it is, and start thinking about, well, what's the volume of exercise or load that I put this person under today and how did they respond to it? And then I'm going to gradually increase this volume. And after that, I'm going to gradually increase the frequency to see if they're getting a better recovery capacity. And then I'm going to gradually increase the intensity and start loading that joint more and more and more with heavier weight or with higher speeds or with bigger ranges of motion. So that's kind of how I think about things. Is I'm looking at volume, then I'm looking at frequency to look at recovery capacity, then I'm going to look at intensity. And once I get somebody that doesn't have a lot of uncomfortable knee pain, well, then I might actually start thinking about strength, or I might start thinking about power and saying, hey, I want you to be able to get up off the floor. I want you to be able to be explosive going up and down stairs. Now that we've habituated your knee to be less sensitive and less painful, let's actually start looking at loading principles from a performance or a functional standpoint.
Yeah. Yeah. So again, you can kind of, your pendulum just swung from the more rehab to performance within one case. And that's often where it moves. And one of the things I think you spoke about there, which I think is worth discussing even a little bit further, is this habituation concept. And this, I think, tendency, especially, I know for this therapist, that when somebody had a painful OA joint or something, it was a lot of this passive, restful, pain modifying. And again, not that that's completely wrong. You can do some, Carol Courtney's done some great work around the OA, doing some just kind of pain modulating mobilizations to the knee to help improve some, some pain scores and different things like that. So you can improve pain through that. But the best way to habituate to a stimulus is adding the stimulus at a level that the body can habituate to. So if you don't have the stimulus they're struggling with in the equation of your treatment, it's going to be, why would you expect them to get better at loading when when they're laying on a bed all day with you doing, because that doesn't feel good. And some patients love it. And I think that can be a big barrier for some people that like it too much, because it can feel great on a bed, but how's it feel in life is the question I always ask patients. And that can obviously be a disconnect for some, but I think you need to be willing to load, and you as a therapist, and if you have implicit fears and avoidance of that stimulus in your caseload, then I think it's something I definitely have had to navigate that earlier in my career, as far as, you got to get over the fact that, joints need to be loaded. There is some pain, and you've brought up some good, kind of concepts as far as how are they recovering. It's a similar thing we talked with Ben Smith stuff around the shoulder, as far as like painful exercise versus non-painful exercise. I think if we make things 0 out of 10 pain contingent, you're going to limit a lot of people's loading capacity, and you're going to limit that ability to habituate if you go into that clinical scenario where you're saying, I can't exercise unless it's a 0. But the other load I would just be mindful of, because I think we tend to want to get into physiology and do percent 1RM and stuff, which again isn't wrong. but what's the psychological load on that patient to start loading their joint? I think then that might be a whole nother podcast, but I think we tend to look at load as mainly just this, mechanical, physiological variable, where I would argue some of the biggest changes I've seen with patients in clinic is when they make this switch of like, you know what, it is okay for me. And good God, you did have me do that leg press, and I can get off of this chair and feel like it doesn't hurt now. I mean, and then you have that conversation with them, they unpack that, and that all of a sudden that psychological load starts lowering, and not because I have a psychological meter that can measure that, because they're telling you it is. You don't necessarily need some sort of, objective measure when they tell you, hey, it is a lot less. I do feel a lot more confident to load this thing. So I think that's one thing I would just look at with it too. But I like, your approach as far as the volume versus frequency versus intensity progressions. Definitely seems to be the way to go about it that I've seen in clinic. That works best for me as well, as far as really looking at going more volume without heavy loads, and then how is this patient recovering, as far as maybe they need a day or between, maybe they need 2 days between loading sessions. If they're really struggling with, some of that conditioned pain modulation, they have maybe a lot more nociplastic pain mechanisms at play, maybe some more top-down type things. Again, we don't have perfect ways to measure that stuff, but again, you can at least have thoughtful ways to approach these things, and thinking of these variables versus looking at a percent chart on your, on your 1RM scale and then going off of that. I think we can do a lot better as far as tailoring that load. What do you think? We could go on for days about this, Jarod. What do you think of? What else do we need to talk about in this episode?
Man, I think that, I really want to talk a lot more about the psychological load aspect of it. And I kind of, I touched on that by talking about, more modern understandings of osteoarthritis. And I think that that's a conversation that we need to have with people to help reduce the psychological load. But I do think that is probably, and that's got to be a separate podcast, because I think that we can go into some pretty good depth on that.
Yeah, no, and that's what our next episode will be. It will be the psychological load of loading, and maybe exercise. We'll play with the title. Jarod and I always like to fiddle with that, but yeah, stay tuned for that. And if those of you who are listening who are having troubles with this in clinic with the real people you're working with, how do I know to regress, progress? Am I doing too much? Am I understanding the psychological load of this patient? How do I do that? How do I even know what psychological load's on the patient? Then feel free to contact us, reach out over social media. We're doing this with clinicians right now in our coaching program, our Complete Clinician Supercharged coaching program, where we have clinicians where we're weekly having coaching calls and discussing cases and discussing these exact topics within your practice, within the people that you're currently struggling with, getting some solutions to those trouble scenarios that you're struggling with, scratching your head with, the same things that we've scratched our head with in the past. And the whole reason we created this program is because we got tired of a weekend with people where we, do our best to instill some of this stuff within them. But then I didn't know how people went forward with what they've learned and how they've been able to apply it in their practice. And I always felt, for me personally, clinically, once that weekend course, it's one thing to see it done on a stage on a Con Ed course. It's a much different scenario when it's with the grind of my really busy schedule in clinic. How do I fit this in? How do I make it work with this unique person in front of me? So if you're interested in looking into that more and getting some coaching or mentoring in your practice, jump on modernpaincare.com/supercharged, and we can have a conversation and see if that's something that's a good fit for you. Jarod and I are confident, and this is the way we want to move forward, because we think this is the best way we're going to be able to help people make the change that was a mighty struggle for us in our practice. So again, reach out to us over social media or via that link, and we're happy to have some discussions with you to see if it's a good fit. Any parting thoughts you have before we wrap this one up, Jarod?
Yeah, I just, like, to anybody out there listening, if you guys enjoy these podcast episodes and you have any like particular specific topics that you would like us to maybe take a dive into, definitely reach out to us, send us a message, comment on one of the posts, get in contact with us any way you can. We're all over social media, so we can actually, maybe develop some content or talk about a topic that you want to hear, because but what are we doing if we're not actually putting out content that is directly what people listening want to hear? So don't hesitate to reach out to us.
Yeah, as you can hear, the last few episodes have basically been episodes. What are our folks in our coaching program struggling with? Well, let's make some episodes on it that might help some other folks who are listening, who are dealing with the same struggles. Because usually one person who's having the same question, there's many more people who've had those same questions. And Jared and I've recognized the questions we're hearing as the same ones we struggled with in clinical practice. So I would echo what Jared said. Yeah, reach out to us. These episodes are to help you guys and to help us move the needle forward of better patient care, better pain care across PT, chiropractic, osteopathic, massage therapy, whatever profession you may be in. Maybe you're a patient who's listening and wants to learn more about some of these things. Obviously, consult a medical professional before you take our word for things, as you want to get a good exam before you do all that stuff. But hopefully these episodes have been valuable to you. Again, reach out if you have any questions, and we will talk to you next time.